Hi, I'm back again. So we're going to move a bit faster this time. We've been doing close to 30 minutes. We'll do 20 minutes now. We're going to look at mechanics of respiration. I won't talk about the outline for sake of time. Of course, I won't also talk about the book we're using for sake of time. But we're going to talk about the two phases of respiration. We're going to talk about the muscles of respiration. So respiration occurs in two phases, namely inspiration and expiration. Now, during inspiration, the thoracic cage enlarges, and the lungs expand. Now that's tricky because you can think, if care is not taken, that inspiration is a positive pressure event. But no, inspiration is a negative intrathoracic pressure event. What is creating the negative pressure is the pleural fluid in the pleural space. So it's sucking in air, and to suck in air, negative pressure has to be created. And when negative pressure is created, the thoracic cage enlarges. So don't think of enlarging of thoracic cage as positive pressure. No, enlarging of thoracic cage is negative pressure. Now, however, when the thoracic cage enlarges, what happens to the blood vessels? The blood vessels will also expand, okay? Because you know now, the blood vessels are connected by fibrous tissue and all that to the thoracic, to the mediastinum. So if it enlarges, they will also expand, and there will be blood flow, more blood flow in inspiration. In expiration, the reverse is the case. In a previous video, I talked about it. So for sake of time, don't let me go over it again. Now, there are two muscles of respiration. As I was saying, respiratory muscles are of two types. There are inspiratory muscles and there are expiratory muscles. And however, there can also be classified, all respiratory muscles, whether inspiratory or expiratory, can also be classified as the primary or major respiratory muscles and the accessory muscles. Yes, this is important clinically because in the clinics, when you start your clinical postings, you're going to be told that increased respiration in adults, which is more than 16, and in newborns, which is more than 60, is known as tachypnea. And tachypnea can be diagnosed by use of accessory muscles of respiration. Of course, aside from increased rate of respiration of more than 16 cycles per minute in adults and more than 60 cycles per minute in newborn, you also have use of accessory muscles. So know that there's something called accessory muscles of respiration aside from the primary muscles of respiration. The primary muscles of respiration are responsible for the increase in size of the thoracic cage or the reduction in size of the thoracic cage. So we proceed. Inspiratory muscles. The muscles involved in inspiration are known as the inspiratory muscles. And then the primary inspiratory muscles are one, the diaphragm. The diaphragm is supplied by the phrenic nerve. Remember, we did talk about the phrenic nerve earlier on when we were talking about the nerves that mediate the cough reflex. Yes. So the diaphragm is supplied by the phrenic nerve, and the phrenic nerve is C3 to C5. C3 to C5. Another primary inspiratory muscle is the external intercostal muscle supplied by the intercostal nerve T1 to T11. T1 to T11. Now the accessory inspiratory muscles include the sternocleidomastoid, the scalene, the anterior serratus, elevators of the scapula, and the pectoral muscles. I'll take that again. The sternocleidomastoid, the scalene muscles, the serratus anterior, the levator scapulae, and the pectoral muscles. Of course, you can remember in our anatomy discussions of the upper limbs, I mean, we talked about these muscles already. You know where some of them originate and insert already. Some of them are in head and neck, so we've not gotten to head and neck anatomy. So we move ahead. Expiratory muscles. The primary expiratory muscles are the internal intercostal muscle, innervated by the intercostal nerves. The accessory expiratory muscles are the abdominal muscles. The abdominal muscles. By way of recap, what are the primary inspiratory muscles? Diaphragm, supplied by the phrenic nerve C3 to C5, and the external intercostal muscles, supplied by the intercostal nerves T1 to T11. What are the accessory inspiratory muscles? Sternocleidomastoid, scalene, levator scapulae, pectorals, and anterior serratus. What are the expiratory muscles, primary expiratory muscles? Internal intercostal muscles, whereby the primary inspiratory muscles are external intercostal muscles. Primary expiratory muscles are internal intercostal muscles. Can we have a way of remembering this? Yes. Primary expiratory, internal intercostal. Primary inspiratory, external intercostal. And we are home and dry. Inspiration causes enlargement of the thoracic cage. We've said this already. Now, so thoracic cage enlarges because of increase in all the diameters. The diameters of the thoracic cage include anterior-posterior diameter, the lateral, the transverse diameter, and then the vertical diameter. Okay? Anterior-posterior diameter and the transverse diameters are increased by the elevation of the rib, while the vertical diameter from top to bottom is increased by the descent of the diaphragm. When the diaphragm contracts, does it go up or come down? When the diaphragm contracts, the diaphragm comes down. That's another counterintuitive stuff, but just have it in your residual knowledge base. You would think that when the diaphragm contracts, it goes up. No, the diaphragm is normally up. It's anatomically a dome-shaped structure, anatomically. So if it were to contract, it doesn't become more dome-shaped. If it were to contract, it goes down and increases the transverse diameter, isn't it? Yeah, transverses. Yeah. How will I say it now? Anyway, increases the transverse diameter, right? Good. So in general, the change in the size of the thoracic cavity occurs because of the movements of 4 units of structures. The diaphragm moves either up or down, either relaxes or contracts. The lower costal series, the upper costal series, and then the thoracic lead. Now, the thoracic lead is formed by the manubrium of the sternum anteriorly and the first pair of ribs. Okay, and it's also called the thoracic operculum. That's the thoracic lead or thoracic inlet. Now, if the thoracic lead moves for any reason, it increases the anterior-posterior diameter of the thoracic cage. Okay, there are some videos on YouTube that you can watch to see these movements, and they are very fine. Now, due to the contraction of the scalene muscle, the first rib moves upwards to a more horizontal position, and this increases the anterior-posterior diameter. Now, the upper costal series refers to the 2nd to 6th pair of ribs. We've talked about the first rib is the thoracic inlet. The 2nd to 6th pair are the upper costal series. So movement of the upper costal series increases the anterior-posterior and transverse diameters. The anterior-posterior and transverse diameters. Now, did I say the diaphragm is increases the vertical diameter? That's what I said, right? Hope I didn't say transverse diameter. The diaphragm increases the vertical diameter. Vertical is top to bottom, isn't it? Now, yes, horizontal is front to back. Vertical is top to bottom. That's what the diaphragm does. The upper costal series, second to sixth ribs, what do? They increase the anterior posterior and the transverse diameters. Okay. Now, movement of the upper costal series is of two types. Second to sixth ribs have two types of movement. They either do the bucket handle movement or the pump handle movement. This can be described very well in a physiology laboratory with some equipment. But the contraction of the external intercostal muscles causes elevation of these ribs and upward and forward movement of the sternum. Again, some YouTube videos show this and it's very fine. I don't even know how to begin to describe it. An upward and the forward movement of the sternum. That increases the anterior posterior diameter. This is called the pump handle movement. At the same time, while this is happening, okay, the central portions of this rib move upwards and outwards to a more horizontal position. This is called a bucket handle movement, and it increases the transverse diameter. I don't even know how to say this, but the pump handle movement, know that we are focusing on the sternum. Pump handle, a borehole pump, that one that you depress and elevate, you depress and elevate. Here we're back. As I was saying, the pump handle movement, our focus is on the sternum. Yes, so remember a pump handle, those boreholes that up and down, that's the movement the sternum does. Naturally, that increases the anterior posterior diameter. So if you got that, you got the pump handle movement, and we can move ahead. The lower costal series include the 7th to 10th pair of ribs. Movement of the lower costal series increases the transverse diameter of the thoracic cage, not by a pump handle movement because there's no sternum there. Okay, so it's by a bucket handle movement. Now, 11th and 12th pair of ribs are floating ribs. These ribs are not involved in changing the size of the thoracic cage. And 11th and 12th pair of ribs, by the way, they are dispensable. We can actually live without them. The diaphragm. The movement of the diaphragm increases the vertical diameter of the thoracic cage. Normally, before inspiration, anatomical position, hold your breath, the diaphragm is dome-shaped with convexity facing upwards. During inspiration, due to contraction, the muscle fibers are shortened, but the central tendinous portion is drawn downwards. That long story is to say that the diaphragm flattens. We've said this before. And this naturally will increase the vertical diameter. If we're happy with that, we move ahead. Now, movement of the lungs. Now, during inspiration, due to an enlargement of the thoracic cage, there's a negative pressure that is increased in the thoracic cavity. It causes expansion of the lungs. During expiration, the thoracic cavity decreases in size to the pre-inspiratory position, and pressure in the thoracic cage also comes back to the pre-inspiratory level. That means expiration makes the thoracic cavity to have a positive pressure. Now, this reduces the size of the thoracic cage and compresses the lungs so that air is expelled out of the lungs. Now, let's talk about lung collapse a bit. Know that the lungs are always under the constant threat of collapse. Always under the constant threat of collapse. Just like every human being is always under the constant threat of falling into sin. That's it. And what are the factors that are responsible for this constant threat of collapse? Two factors. The lung is very elastic. In your dissection classes, you would have seen the lung. You can press the lung like a foam on a table and press it so much, it's so elastic. Elastic tissues of the lung are always attempting to recoil. They are always attempting to shrink. The lung is not always attempting to rise. It's always attempting to shrink. Okay, so it is the movement of the thoracic cavity, or what we have described now, that makes the lung to increase. If you leave the lung alone, it's always trying to shrink. The way if you leave human beings alone, they're always trying to sink. Same thing. Now, as I was saying, the lung has a constant threat to collapse. Now, second thing, why it always has a constant threat to collapse. The first one was the elastic property of the lung. Second one is surface tension. Is the tension exerted by the fluid secreted from the alveolar epithelium on the surface of the alveolar membrane. Okay, that's basic. Fortunately, there are some factors that provide salvation to the lung and prevent it from collapsing. Now, factors that provide salvation to the lung and prevent the lung from collapsing, in spite of the fact that the lung always threatens to collapse because of its elastic property and because of the surface tension in the alveoli of the lungs, the intrapleural pressure is always negative. Know that the intrapleural pressure is a sort of vacuum. It's a negative pressure environment. It's a vacuum. Just think of it as a vacuum, because that is what it is. And so it's always negative. And because of that negativity, it is constantly keeping the lungs expanded, attracted towards the pleural sac. Yeah, attracted towards the pleural sac. Sucking it to itself. It's interesting. The pleural space is in a constant state of constantly holding the lungs open to itself like that. Just the way the Holy Spirit is constantly holding us open to God. If he takes himself away, we just shrink back to our normal sinful selves, all of us. The surfactant, it's a substance secreted in the alveolar epithelium to do what? To reduce the surface tension. Because with that surface tension, the lung will collapse. Surfactant is like soap. And what the soap does is that it reduces surface tension. Good. Now, surfactant is a surface acting material, surface acts, or agent that is responsible for lowering the surface tension of fluid. Some water, for instance, just an illustration, are referred to as hard water. Why are they referred to as hard water? Because there are properties in that water that make it difficult for you to use that water to wash your clothes, to wash your plates, or whatever. But when you add some agents to that water, it makes that water soft and pliable and easy to wash your clothes or your plates with. That's what surfactant does. If you take surfactant away, the lung will be hard as wood. But if you bring surfactant in, the lung will be soft as foam. This is very important. And it's the softness of the lung that makes the lung to be able to respond to that negative pressure of the pleural sac pulling it. If it's not soft, the pleural sac can do all it wants. If the lung is hard as wood, the lung will not even listen to the pleural sac. It will just stay where it is. This is what we are trying to describe. If you understand this, it's very interesting. And so the surfactant lowers the surface tension. And surfactant that lines the epithelium of the alveoli in lung is known as pulmonary surfactant. And we have said what it does. It decreases surface tension. Now, what are the sources of secretion of pulmonary surfactant? Pulmonary surfactant is secreted by Clara. I can't forget Clara. Clara cells are situated in the bronchioles. I don't know why we're named Clara. These cells are also called bronchiolar exocrine cells. 2. It is also secreted by type 2 cells. I said it like this to make it easy for you to remember. Surfactant is secreted by Clara 1. Clara, no one there. That's the first thing, which is situated in the bronchioles. These cells are also called bronchiolar exocrine cells. 2. Surfactant is secreted by type 2 alveolar epithelial cells, which are also referred to as the surfactant secreting cells or the pneumocytes. Characteristic features of these cells is the presence of microvilli on their alveolar surfaces. Now let us look at the chemistry of surfactants. Yes, quickly, surfactant is a lipoprotein. And lipoprotein means it has lipids and it has proteins. So once you know that, you're 50% gone. Lipids, proteins. That is why it's called a lipoprotein. Now, it contains 1, phospholipids. Phospholipids consist or form about 75% of surfactant. And the major phospholipid in surfactant is DPPC. Please don't forget this. Have it in your residual knowledge base. Spinal level, C5. At the snap of a finger, it should come out. DPPC, dipalmitol phosphatidylcholine. I learned this in my 200 level, I don't know how many years ago. Honestly, it's over 15 years ago, and I haven't forgotten it. It's at residual level. I don't need to read it again to remember it. Please know it. Dipalmitol phosphatidylcholine. Now, other lipid substances of surfactants are triglycerides and PG, phosphatidylglycerol, PG. So DPPC, PG, you are making progress. Proteins of the surfactants are called specific surfactant proteins. Just know proteins. SP, surfactant proteins. SPA, SPB, SPC, SPD, that's it. So SPA and SPD are hydrophilic because the surfactant is like soap. Now, if you have understood the chemistry of soap, soap has 2 ends, a hydrophilic end and a hydrophobic end. Now, the hydrophilic end is going to make hard water or whatever, water generally, soft because it is going to make the material you're trying to wash to love the water. If you're trying to wash plate, the hydrophilic end is going to face the water and buffer the water to itself and make the plate love the water. So the plate will just be having intimacy with the water. This is very important. That's what soap has. And it also has a hydrophobic end. The hydrophobic end stays inside, away from the water. All soap have this. Surfactant is basically soap. It has a hydrophilic end and a hydrophobic end. So the hydrophilic end makes the lung soft and pliable, water friendly. And that hydrophilic end is AD, SPA and SPD, while the hydrophobic end is BC, SPB and SPC. If you get this, you're done with surfactants. Nothing else again. Ions are present, and the ions are mostly calcium ions. So the only other thing you need to know about surfactants are the, formation of surfactants. The type 2 alveolar cells and Clara cells, they have lamellar bodies, which form the intracellular source of the surfactants. Okay? and so on and so forth. What are the factors necessary for the formation and spreading of surfactant? Now, glucocorticoids play an important role in the formation of surfactants. That's a highlightable information. Because if you're going to be giving a multiple choice question in your test, it's a good one. But they might give you a theory question. I mean, your test might be all theory, really. So if it's all theory, settle down and write all these things we're saying and get your 95% and leave there. We've talked about SPB and SPC. Is SPB and SPC hydrophilic or hydrophobic? It's hydrophobic. SPA and SPD is hydrophilic. So we are happy with that. We can quickly move ahead because time is already running. What are the functions of surfactant? We have said one already. Reduces surface tension. Functions of surfactant. It reduces surface tension. This is residual knowledge. This should be at spinal level, C6, please. Surface tension reduced by surfactant. And it prevents the collapsing tendency of the lungs. Surfactant acts by the following mechanism. The phospholipid portion, the phospholipid molecule has two portions. One portion of the molecule is hydrophilic, which is SPA and SPD. The other portion is hydrophobic, which is SPB and SPC. Now, the hydrophilic portion dissolves in water and makes the alveoli love the water. The hydrophobic portion is directed towards the alveolar air. So this surface of the phospholipid, along with other portion, this hydrophobic portion, spreads over the alveoli, facing alveolar air and resisting collapse. The hydrophobic portion spreads, points towards the alveolar air, resisting collapse. Know that there's always some fluid in the lung. There's always some fluid in the lung. All this blood flow we have been describing since, at a point, some fluid is going to seep out from the capillary and stay in the lung. And if you don't have surfactants, that fluid is going to make the lung hard as wood. It's going to make the lung unresponsive to the negative pressure of the pleural sac. But with the surfactant, the hydrophilic portion points towards the water or the fluid, and then the hydrophobic portion points towards the air. And it spreads around like that and stays like that. Listen, God is a great God. Now, the SPB and SPC play an active role in this process. SPB and SPC are the hydrophobic. Surfactant is responsible for stabilization of the alveoli, which is necessary to withstand the collapsing tendency. It's like grace in a Christian's life. Withstands collapsing tendency. You don't collapse. You don't collapse. The lung don't collapse. Why? Because of the surfactant, the Spirit of God in the life of a person prevents him from collapsing into sin. It plays an important role in the inflation of the lungs at birth, after birth. In the fetus, the secretion of surfactant begins after the 3rd month. Until birth, the lungs are hard as wood. When the fetus is in his mother's womb, is swimming in amniotic fluid, and there's fluid everywhere, including all over the lungs, and the lung is hard as wood. But 3 months after birth, surfactant starts getting secreted. Soon after birth, the first breath starts because of the stimulation of the respiratory centers. What stimulates the respiratory centers in the baby? Sudden hypoxia. when the baby is in its mother's womb, there is no hypoxia. Why? The baby is like an organ in the woman's body. The woman's body is continuous with the placenta and continuous with the baby. So the way oxygen goes to the leg and to the hand is the way oxygen goes to the placenta and to the baby. So the baby is receiving oxygen just the way the woman's brain receives oxygen. The moment the baby comes out, it's just like a part of the woman's body has come out of her. That baby has the capacity in itself to begin to breathe. And what makes it to begin to breathe is a sudden realization that I don't have oxygen. Baby thinks it's going to die. And that thinking is going to die is why the baby screams. Wow, I don't want to die. God made it that way from Adam. And that sudden screaming is because of hypoxia. I think I'm going to die. And as that happens, the respiratory centers are activated by hypoxia and hypercapnia. This is a very interesting information and is highlightable. Respiratory centers in the baby soon after birth are stimulated by what? Hypoxia and hypercapnia. So although the respiratory movements are attempted by the infants, the lungs tend to collapse. The lungs are just funny, they tend to collapse. But the presence of surfactant in the alveoli prevents the lung from collapsing, especially as from 3 months. So within first month to 3 months, it's important to always keep an eye on the baby. The baby can roll over, face down, or maybe it doesn't roll over, can use cloth and cover his face and can just asphyxiate, not breathe, and pass and die. So you need to keep an eye on the baby. But when the lungs are maturing, that's the reason why in premature babies, if we anticipate the birth of a premature baby, we give some glucocorticoids. We give some steroids to the mother, dexamethasone injections. To do what? Stimulate what? Production of surfactants. That's what we're trying to do. Stimulate production of surfactant to make the lungs mature. Maturity of the lung, ripening of the lungs, like a fruit ripening on a tree, has to do with surfactant production. So if we know that this woman is going to deliver at 7 months or at 8 months of her pregnancy, and maybe because of the way the pregnancy has been going, we start giving her dexamethasone, giving her steroids, glucocorticoids have a role to play on time. Another important function of surfactant is its role in defense within the lungs against infection and inflammation. Now, the hydrophilic proteins, SPA and SPD, they destroy bacteria. And they destroy bacteria. They destroy bacteria by opsonization. What is opsonization? They coat the bacteria. Opsonization is to coat. So when they coat the bacteria, they choke it. Now, if there is deficiency of surfactant, you have respiratory distress syndrome. In adults, you call that adult respiratory distress syndrome. In infants, it is called hyaline membrane disease. Hyaline membrane disease, also called respiratory distress syndrome. Now, respiratory pressures. Good. Now, there are 2 types of respiratory pressures. There's the intrapleural pressure or intrathoracic pressure in the pleural space, which is it possible a negative pressure? It is a negative pressure. Intrapleural pressure is the pressure existing in the pleural cavity, that is between the visceral and parietal layers. It's exerted by the suction of the fluid that lines the pleural cavity. I've described these suctions too many times already. It is also called intrathoracic pressure since it is exerted in the whole thoracic cavity. Normal values. Respiratory pressures are always expressed in relation to atmospheric pressure. Atmospheric pressure is 760. Under physiological conditions, the intrapleural pressure is always negative. On that physiological condition, the intrapleural pressure is always negative. Normal values are, at the end of normal inspiration, -6. At the end of normal expiration, -2. At the end of forced expiration, -30. At the end of forced inspiration with a closed glottis, the Muller's maneuver, -70. When you want to cough, see how high the pressure is. That's why you can force out air forcefully at almost about 960 millimeters of mercury pressure. At the end of forced expiration with a closed glottis, plus 50 millimeters mercury. So you can see that the intrapleural pressure is mostly a negative pressure. Pleural cavity is always lined by a thin layer of fluid that is secreted by the visceral layer of the pleura. Now, this fluid is constantly pumped from the pleural cavity into the lymphatic vessels. Pumping of the fluid creates a negative pressure. So what creates a negative pressure? The pleural fluid is not just there, static. In a living person, it's not static. It's being pumped into the lymphatic vessels. And so that pumping into the lymphatic vessels generates a negative pressure, just like the fluid is constantly being pumped into the lymphatics. Now, intrapleural pressure, however, can become positive in one situation. What situation is that? Valsalva maneuver. As I was saying, the intrapleural pressure becomes positive in Valsalva maneuver. Valsalva maneuver. And in some pathological conditions such as pneumothorax, hydrothorax, hemothorax, and pyothorax, it becomes positive. So it can be measured by a direct and indirect method. That's intrapleural pressure. In a direct method, the intrapleural pressure is measured by sticking in a needle and connecting the needle to a mercury manometer. Now, in the indirect method, it's measured by introducing a balloon. The balloon is connected to a manometer, a pressure measuring instrument. And signs of significance of intrapleural pressure. Now, throughout the respiratory cycle, the intrapleural pressure has to remain lower than the intraalveolar pressure. It has to remain lower. This is what helps the lungs to stay inflated. That's the suction thing we have been describing since. Okay? So the intrapleural pressure has two functions. It prevents the collapsing tendency of the lungs. It prevents the collapsing tendency of the lungs. Because of the negative pressure in the thoracic region, the larger veins are enlarged. That is, they are dilated. Also, the negative pressure acts like suction pump. We happy? The negative pressure acts like suction pump and pulls the venous blood from the lower part of the body towards the heart against gravity. Thus, the intrapleural pressure is partly responsible for venous return. So it is called the respiratory pump for venous return. Intraalveolar pressure. Intraalveolar pressure is the pressure existing inside the alveoli. It's also known as intrapulmonary pressure. It's always higher than intrapleural pressure. The intraalveolar pressure is often equals to the atmospheric pressure. So it's really high, 760. Meanwhile, the intrapleural pressure is -6 at the end of normal inspiration. So you can see the difference. So this is a very effective suction. However, intraalveolar pressure changes. It becomes negative during inspiration and positive during expiration. Negative during inspiration, positive during expiration. During normal inspiration, -1 millimeter mercury. During normal expiration, +1 millimeters mercury. at the end of inspiration and expiration equal to atmospheric pressure. During forced inspiration with a closed glottis, molar maneuver is minus 80 millimeters mercury. During forced expiration with a closed glottis, it is 100 millimeters mercury. Now, intraalveolar pressure is measured using a plethysmograph. We talked about a plethysmograph before when we're talking about measuring volumes and capacities that cannot be measured by spirometry. What are the significance of intraalveolar pressure? Intraalveolar pressure causes flow of air in and out of what? The alveoli. During inspiration, the intraalveolar pressure becomes negative. Why? To suck. Negative pressure is for suctioning something, sucking something. So during inspiration, the intraalveolar air becomes negative. So the atmospheric air is sucked. So the air doesn't just flow into your nose. The air is being sucked into your nose. During expiration, intraalveolar air becomes positive. So air is expelled out of the alveoli. Air doesn't just flow out of your nose. Air is forced out of your nose. Now, intraalveolar pressure also helps in the gaseous exchange between the alveoli and the blood. Transpulmonary pressure is the pressure difference between intraalveolar and intrapleural pressure. Yeah. Now, compliance, we will rush through compliance. It is the ability of the lungs to expand. It's the expansibility of the lungs. And we have said the lungs is elastic. We have said the lungs always have a tendency to collapse. They are always under the threat of collapse, desiring to collapse, wanting to collapse. So something has to just stop them from collapsing. So we have been describing things. However, apart from always wanting to collapse, the lungs themselves are elastic, like an elastic band. Now, the determination of compliance is useful as it is a measure of the stiffness of the lung. The more the lung becomes hard as wood, the less the compliance. We use the language hard as wood, not because the lung ever becomes hard as wood, but we use that language hard as wood to make students appreciate the beauty of nature. In pneumonia, there's consolidation, and consolidation is when the lung starts becoming hard as wood. That's what happens in pneumonia, really. Now, a normal lung has compliance. A pneumonic lung has started losing its compliance, by the way. Now, compliance is expressed in two ways, in relation to intraalveolar pressure and intrapleural pressure. That's what we've been describing since. Now, compliance in relation to intraalveolar pressure is the volume increase in lungs per unit increase in intraalveolar pressure. In relation to intrapleural pressure is the volume increase in lungs per unit increase of intrapleural pressure. And that's what it is. And there are values for that. You may wish to look up the values for sake of time. Just know that compliance is what? Is the ability. In life, we must always learn to speak of abilities. And this ability comes from God. This ability is not coming from man. He just has this ability of the lung to expand. And it is the expansibility of the lungs and thorax. Do we understand this ability now? And this ability is in relation, it's always in relation to something. In relation to the intrapleural pressure, in relation to the intraalveolar pressure. Now, if the lungs could be removed from the thorax, the compliance of the lungs alone will be doubled. It's because of the absence of inertia and restriction exerted by the structure of the thoracic cage, which interfere with expansion of the lungs. So the lung is very elastic. That's what it's trying to say. If you bring it out from the lungs, you press it so much, press it so far, press it so much, it just keeps pressing. And if you take your hands up, it just keeps rising back up to its former state until it gets to its former state. You press it so much, press it so far, press it so hard, it keeps going down. And you remove your hand, it just keeps rising back to its former state. That is lung on the table. That's how lung is. Lung in the chest is not like that. Because lung in the chest, there's a lot of intra-alveolar pressure, intrapleural pressure, making it to do like this and do like that. Now, specific compliance, the term is used to access the stiffness of the lung tissues more accurately. Specific compliance is the compliance per liter of lung volume. Now, we've talked about capacities. Functional residual capacity is the volume of air present in the lungs at the end of normal respiration. And functional residual capacity is made up of what and what? Residual volume and expiratory reserve volume. Types of compliance. We are almost done for today. Compliance of two types, static compliance and dynamic compliance. We've looked at this before, so let's rush through it. Static compliance is a compliance measured under static conditions. Static conditions like what? You're hiding behind the door, holding your breath because there's a lion in the walkway. It measures pressure and volume when breathing does not take place. Static compliance is the pressure required to overcome the elastic resistance of respiratory system for a given tidal volume under zero flow. Zero flow. You are underwater for those that swim, and you can stay underwater for 5 minutes because you're an expert swimmer. When you are underwater holding your breath, that's zero flow. Your lung is in a state of static compliance. Dynamic compliance is a compliance measured by dynamic conditions. As I'm talking now, I'm breathing. It's a dynamic condition. So, in a healthy person, there's a little difference between static compliance and dynamic compliance. In patients with stiff lungs for any reason, stiff lungs because of pneumonia, because of cystic fibrosis, because of anything that makes the lung to be hard as wood, the dynamic compliance decreases. If I have stiff lung, if I have pneumonia, simple example now, pneumonia, it means that the ability of my lungs, as I'm talking now, to expand reduces. What we are saying. A patient with stiff lungs or the dynamic compliance decreases with little changes in the static compliance. If I hold my breath, if I have pneumonia, well, I am holding my breath. But then, if I decide to breathe normally, the ability of my lungs to expand is going to be severely hampered depending on the severity of the pneumonia I have. Now, measurement of static compliance. To measure static compliance, the subject is asked to inspire air periodically at regular steps from a spirometer, and so on and so forth. Measurement of static compliance is used by a spirometer, actually. Now, at the end of each step, what step? The patient is asked to inspire air from a spirometer. In your physiology lab, there will be a spirometer there if you have a good lab. If you don't have a good lab, just imagine a spirometer. The patient is asked to inspire air from a spirometer. Inspire air. A known volume of air is inspired. Then the intrapleural pressure is measured. How do we measure intrapleural pressure? They have told us you can use direct method, you can use indirect method. Direct method can be done with a needle, indirect method can be done with a balloon. Check it out. Then the air is expired in steps. The inspired air is expired in steps until the volume returns to the original volume. Now, the values of the volume and the pressure are usually plotted on a curve. And this curve is called the volume pressure curve, with the volume on the y-axis and the pressure on the x-axis. Now, this volume pressure curve, the expiration curve is usually convex. Then it flattens out. While the inspiration curve is what? Concave, heading for a peak. What this means simply is that at an intrapleural pressure of -5 centimeters of water, the lung volume can rise up to 300 mils in expiration. But at a pleural pressure of -5 centimeters of water, the lung volume can only get up to 100 mils on inspiration. Which means that for inspiration to get the lung volume to 300 mils, it needs a